So, total knee arthroplasty is a common procedure that involves a high postoperative pain response in a significant number of patients. And glucocorticoids have become a standard component of opioid-sparing multimodal analgesia for total knee arthroplasty. The analgesic effect is achieved at doses higher than those used to treat postoperative nausea and vomiting. And the effect is thought to stem primarily from an anti-inflammatory properties. The general recommendations suggest a preoperative dose above 10 milligrams of dexamethasone. However, the optimal dose to improve early postoperative pain is still unknown. Additionally, recent studies have suggested that certain predicted high pain response patients, based on factors such as pain catastrophizing levels, may benefit from increased doses of dexamethasone up to 1 milligram per kilo. And studies in general knee arthroplasty populations have suggested an additional effect of repeat dose glucocorticoids the day after surgery. However, no studies have tested the efficacy of repeat dosing in high pain response patients also receiving a high preoperative dose. The current study was a double-blind, randomized, placebo-controlled trial conducted at 2 major arthroplasty centers in Denmark. The study looked specifically at high pain response patients who were selected based on 2 primary inclusion criteria. The first being that they had to have high pain catastrophizing, and then they had to have moderate to severe pain during walking 24 hours after their total knee arthroplasty surgery. So it's a highly selected patient group. And these factors have been found to be predictive of a high pain response 48 hours after surgery. All the patients received a high preoperative dose of dexamethasone of 1 milligram per kilo, which was equivalent to the dose that was found effective in these high-risk patients. And the study tested whether giving an additional oral dose of dexamethasone of 24 milligrams on postoperative day 1 would further reduce pain compared to a placebo. The study found no statistically significant reduction in moderate to severe pain 48 hours after surgery between the dexamethasone and placebo groups in this highly selective patient population. However, a small trend towards lower pain in the dexamethasone group was found at certain later time points, although this was not clinically meaningful. And overall, the opioid use, quality of sleep, nausea, and other side effects, as well as secondary outcomes, were similar between the groups. These findings suggest that adding a repeat dose of glucocorticoids may not provide further clinically meaningful pain reduction in these high-risk patients when high preoperative doses of dexamethasone are already given. One reason for this may be that the high preoperative dose still had an effect when in the period of the primary outcome, such that the repeat dosing did not provide further benefit. We still need further research focusing on the optimal dose and timing. For instance, what combination of preoperative and postoperative dosing regimes is optimal. And more importantly, future studies should focus on the right patient subgroup. We did manage in this study to find a highly selective group of patients with a high pain response. However, there may be specific patients who benefit from increased doses based on genetics or their inflammatory response. And finding these patients could help target individual treatment, not only for glucocorticoid treatment, but also for other opioid-sparing techniques.